All right, Dr. Daniel Kreuzer, thanks a lot for agreeing to do this testimonial for us. We'll try and make it fairly quick here. The whole point of this is just to give some patients and other providers, family physicians, as well as physiotherapists out there some more information about the outcomes accountable care system. So why don't you just start off and give us just a brief bio?
Yeah, sure. So yeah, as you said, my name is Dr. Daniel Kreuzer. I've been working in London, Ontario now as a primary care physician for the last 3 years independently or so. Did my undergraduate degree at Western in microbiology and immunology, honor specialization. Completed that in 2009. Finished med school at UWO in 2013, and I completed my family medicine residency in 2015. But yeah, no, enjoying family practice, but I certainly would say that despite best attempts in residency for teaching musculoskeletal disease presentations and how to diagnose and treat them, it still is somewhat lacking. And it was a pleasant surprise to find the MAC network, I'll say.
Awesome. Yeah, well, you just led into my first question, which was, well, we'll go back a bit. What was your practice like in terms of treating, triaging and managing musculoskeletal conditions in your private practice before you found out about the outcomes accountable system?
Yeah, sure. So the standard, very good history and physical, and then kind of relying on imaging modalities to have a very, very anatomically based diagnosis. And then I guess the struggle from there is you would link the patient with a physiotherapist or other allied healthcare provider that they had, previously had, connection with or relationship with, or randomly choosing a physiotherapist and not exactly knowing what type of treatment they would get, whether it be modality based, meaning they just get ultrasound or TENS, or the person's only been focusing on massage only and they're not really getting better. So it was a bit of a struggle to find routine, sort of, there's some continuity in like the level of care people were being provided for, because again, I think from physiotherapy clinic to clinic, you would sometimes have differences in diagnosis or types of treatments offered, which would actually vary quite significantly.
Yeah, I always tell people, you walk into 10 different physiotherapy clinics, you'll get 10 different answers in terms of what the source of your problem is and 10 different treatment plans potentially. Mm-hmm. The variability in diagnostics in MSK is quite high. It's one of the problems that we're addressing with MAC. So yeah, okay, well then what happened after you started, or some of your patients started seeking out outcomes accountable care? Did you notice any differences?
Yeah, big differences. I'd say initially what people notice is often they would get better or nearly completely better, like very quickly, whether it be acute or even chronic conditions where people are having just mind-boggling improvements in their chronic pain. People have decades of chronic shoulder, neck, low back, sciatica, quote unquote, with very significant improvements. But what I found interesting was, for me, that it's such an algorithmic approach to delineate the potential problem, what's going on. It not only is diagnostic, but it's therapeutic in its process and also prognostic. So you can kind of say, well, if this isn't working, what are the next steps? We're not floundering for weeks and weeks and weeks, and people are getting hemorrhaged for money, even if they do have insurance benefits, because no one wants to flounder for weeks and weeks and weeks. And historically, I have seen out of my patients where they will see, and again, this isn't to denounce certain allied healthcare professionals, but at times I'd see someone going to a chiropractor just doing rapid manipulations for like 2 years, and yes, they get some short-term unsustained pain relief, but no real meaningful change to their pain syndrome long term. And I would see a complete opposite of that when they started to attend accountable care type physiotherapy regimes like with MAC.
Yeah, that's the whole matching the diagnosis, the underlying cause with the appropriate treatment. And that's what we do. I think very, very effectively is that categorization or that subgrouping, where we can use pattern recognition, and we can use a very science-backed, literature-backed, validated, and reliable assessment process to then subgroup those people into into subgroups that are predictive of outcome and predictive of prognosis. And oftentimes there's individuals that get sent to physiotherapy that aren't good physiotherapy candidates, and they shouldn't be there. Sometimes it is appropriate to have them on medications or have them get the right imaging, and then refer them to the appropriate specialist. So yeah, we're not interested in continuing down a conservative care pathway with individuals who are structurally compromised that need surgical intervention. And likewise, we're not interested in having people sent down the specialist and surgical pathway who have an underlying directional preference or rapidly responding condition that just need the right movement strategy to resolve that problem, and just need some coaching and somebody to look at their lifestyle and to look at their individual factors to then get them engaged and motivated to do the thing that needs to be done to get the problem better. So yeah. Do you have any particular stories or cases that you can recall that were treated effectively with the outcomes accountable care system?
Yeah, plenty. There obviously one gentleman, I think you know him well. He had chronic upper back and neck pain for many years, and this was after he had a neck surgery remotely. Obviously had some loss of range of motion, but suffered significantly with pain. It's very interesting though, because he had gone down the pathway of numerous different types of modalities of treatment, never really had any improvement. Was using anti-inflammatories relatively routinely. I think at one point was potentially going to have a shoulder surgery because he was having such bad referred potential shoulder pain associated with his pain syndrome. And once he saw you guys, he had such an improvement so drastically initially with some of this directional preference movement that he himself was just floored by it. Like almost it was I think during your assessment was just sort of couldn't believe how much improvement he actually was having real time. Obviously, with the chronicity of his issues and whatnot, he's needed to continue with the movements. But that's another thing I mentioned to answer in the last question was that a lot of my patients who see such a significant improvement, they're empowered to continue doing some of these directional preference movements, not only to treat if pain does come back, but also prophylactically or preventatively down the road to prevent recurrences of their pain. And whereas a lot of the time, you'll see certain, I'll say MSK providers sort of mentioning that, well, you need to see me, I have the hands of God, so to speak. I'm the person that needs to do this. They often can do these movements themselves safely with their own kind of neuromuscular system. And you're not risking certain injuries and whatnot with rapid manipulations that sometimes you'll see with chiropractic care. So it's just fascinating to me just to see. I think another case I remember was I had a very elderly lady with some cervicogenic dizziness and every other possibility of dizziness, vertigo, lightheadedness, disequilibrium was entertained, and we weren't really getting to the bottom of it, but it ended up. It seemed to be, at the end of the day, cervicogenic, meaning coming from a cervical spine, and with just some simple retraction and extension, like her dizziness was 100% resolved. That's what's so interesting to me. It wasn't like, oh, it's a bit better. It was just gone. And literally, we didn't do anything else. There's plenty of times I've had.
Did you do that? Was that in yourself?
No, I think you ended up seeing the patient and kind of like, I think I had given her like just some preliminary retractions to do, but she needed a little bit more teaching and coaching and the appropriate movements. But there's been plenty of times I've had people with neck pain, shoulder pain, and I've given them even just simple retractions to do. And honestly, you probably haven't even seen like 50 patients of mine because they never needed to see you, because I gave them the rudimentary directional preference movements that the large majority of people will respond to, right? Including low back pain with the sciatica. Like honestly, it's flabbergasting to me the number of times I've seen someone done some neurological examination. There's no red flags. And then I give them a prescription, so to speak, of repetitive end range lumbar extensions. And they're like, I think I told you the other day, there was a patient of mine, never saw you. I just recommended this. And he'd been struggling with sciatica probably for like 15 years. Messages me after I give him the prescription after like a week. And he's like, I have no back pain or leg pain at all. And like, I feel like I could do backflips. And like, I didn't even see this guy in person.
That was a prescription of extension exercises, lumbar
Correct.
extension, just
lumbar extensions.
One simple movement.
Yeah.
Felt pretty good.
And so it's kind of interesting that, he got this sort of primer book, the Treat Your Own Back. And that's literally all I recommended to start. And I had planned up to follow up with him and examine him. I didn't even have to. Like, it was just so mind blowing. That doesn't happen in medicine. Like, it doesn't happen in musculoskeletal conditions. Like, this is what's so interesting to me, that like Canada, we don't see this as uptaken in Canada as it probably should be. But again, it's probably more related to the business side of some of the musculoskeletal sort of treatment industry, if you will, because
it's very lucrative for people to be in pain and to stay in pain. There's a lot of
But which is why when people end up getting this treatment and say they've, even if they're not a rapid responder, and after 4 or 5, visits to delineate what directional preference they may need for their back or their neck or whatever, their shoulder or their knee, whatever, they will still be flabbergasted, because half the time they've been struggling for a long period of time and they're not anymore. And so they feel empowered, and they don't, I will say, I've definitely been seeing the last 2 or 3 years recurrences of the same issue, because most of these patients have been streamlined through MAC, accountable kind of care. And so they know how to treat their own recurrences of pain. So I don't see them as much as a consequence, because people are empowered to treat themselves after they've been seen and given the, they went through the algorithmic approach to really know how to treat their musculoskeletal disorder well and right the first time.
Yeah. Wow, that's super interesting you say that, because I actually can't wait to start tracking some data with you guys, with family physicians, just to figure out if we can have a tangible impact on your guys' clinical practice, just by giving you the education about these easily reversible problems, so you guys can capture just the low-hanging fruit and get individuals, even people with, like you said, chronic pain, even severe subacute, even acute pain. You can see the drop in pain intensity quite dramatically in some of these cases where you get a reversible change, and people are walking out of your clinic in a better state. And not only is that just rewarding from a clinical standpoint, because why did most family physicians get into the profession in the first place? It was to help people, and you've helped somebody dramatically in a very short period of time. But also, just overall, you may notice that people are self-managing a lot better.
A trend,
wanting to go to your office, not ending up in walk-in clinics or going to emerge all the time.
Or getting unnecessary imaging, that's not going to change their management whatsoever. And if anything, potentially leads them an inappropriate pathway for procedures or surgeries that aren't really needed, and put them at undue risk, and potentially won't actually even help them. It's funny you mentioned the whole rewarding thing, because I think probably the most rewarding case I ever had wasn't even one of my patients. It was actually in an after-hours clinic for one of my colleagues. And I remember thinking, how is this young kid, I mean, I say kid, but he's probably like in his 30s, but just a very fit, like tall guy, comes in kind of hobbling with an antalgic gait, just not looking well, the classic sort of sciatic gait, if you will. And he was describing this very intense acute low back pain and with radiation down the back of his leg. I'm like, what the heck? Did you have any injury? And I went through the history of them, and it didn't make sense, except for the fact that he'd been in a probably very poor posture for months, studying for some examinations. And I remember just examining him briefly to rule out any red flags, and then just taking him through like 30 prone, so laying on his stomach on the examination table, lumbar extensions. And he was a strong guy, so he could really get to end range really well by doing this. People may understand it as like a lazy push-up, but it was more of a sustained, end range movement. And he after the 30, he sort of sits up and I'm like, do you have any pain anymore? And he's like, no. I'm like, you don't have any back pain? He's like, nope. Do you have any leg pain at all? He's like, I do not. And he stood up and just sort of walked out of the exam room. And I was like, yeah, great.
Yeah.
So clearly he had a lumbar derangement because of his terrible posture over, as you know, immobilized for the last like 3 months. His father was sitting there, was just like completely shocked, thought that poor guy was going to need all this therapy, so on and so forth. And I'm like, you know, recommended the book, you know, I discussed that, you know, we could get him through to sort of musculoskeletal accountable care if he needed in the future, but he can perform these movements himself at home, even like 10 in the morning, 10 at night, whatever, 10 in the middle of the day, just to cut it, especially if he's been sitting so much like this, right? So he was just absolutely empowered because he's like, oh, wow, like I'm not in any pain at all right now. And clearly he was a rapid responder. Some people aren't, and you know, some people don't respond at all, which is a minority. But then at least you know where to send them potentially, whether they need like an epidural steroid injection or to see a neurosurgeon, et cetera. The list goes on and on for potential options after this type of algorithmic approach. But just that was probably the most rewarding case I've ever seen. I think about it all the time, and it's just, you know, you don't get a case where you're like, I'm in terrible pain, and the person leaves in no pain. And again, I didn't put any words in his mouth. I'm like, oh, he's go down to 10%. Like he's like, I don't have any pain at all. I'm like,
Yeah.
great.
Yeah, it's like that. It's like that beautiful drive on the golf course where you hit it straight down the pipe, and then that's
300
back.
Yeah.
Although, although I mean, once you get, you know, it doesn't take you too long to get good at this and actually start really identifying a lot of patients. And I think that's one of the more surprising things is that there is a ton of rapid responders out there. Boy, like the data that we have now, 80% of individuals with some component of a rapid reversible problem underlying their mechanical pain is quite fascinating stuff. So anyway, thanks for sharing your story, your experiences, and the testimonial today. And I hope that we can start spreading the word about this to everybody else.
Yeah, my pleasure. My pleasure to help.